Hi guys, this is Dr. Brian Mann coming at you from the University of Miami. For those of you who didn't know, I'm in the Department of Kinesiology and Sports Sciences here, as well as the Strength Conditioning Master's Program. And I wanted to give you an example of some of the information that we go over in our classes I think might be helpful. Today I wanted to shift gears. We've been going over a lot of studies, and I wanted to shift gears to the shoulder. I think that many strength and conditioning coaches, I know for a fact from the people that I've worked with and interacted with that there's a great number of people who are having not the most scientific background or anatomically related background. So I want to go ahead and record a few videos to give you guys a little bit more information about this. And I really want to go over the rotator cuff today. And to go over the rotator cuff, we've got to start at the glenohumeral joint. Well, what do we need to know about the glenohumeral joint? Well, it is the most mobile bone in the body. It's a ball and socket joint. It has 3 degrees of freedom. And for those of you who don't know degrees of freedom, that just means how many axes can it go around, how many cardinal planes of motion. And it goes in all of the cardinal planes of motion. Now, it typically will have a high degree of congruence between the humerus and the glenoid fossa. We've got some musculature that its sole goal is to keep that sucker sucked in, the head of the humerus, sucked in onto that glenoid fossa. Because when we have a high congruence, so that the head of the humerus sits nice in the dead center of that glenoid fossa, that will greatly reduce the stress to the joint. Because we've got structures like the labrum and some other things that are going to help cushion the blow, so to speak. Now, we also have no bony limitation to motion, which is good in the fact that it allows such a great degree of motion to be occurring. The downside, though, is that decreases the stability. Now, the other ball and socket joint that everybody always thinks of is the hip, right? So, with the hip, they've got the head of the femur, the femoral head, and it sits into the acetabulum. Now, acetabulum actually means vinegar cup in the Latin, and that's because it's deep, like the cup that they would have like balsamic vinegar in to dip their bread. So it is very, very deep, and that's what promotes the amount of stability. Think about just watching a sporting season. You'll see hopefully you don't see a tremendous amount of shoulder dislocations. The hip dislocations you don't see very often because it's got a tremendous amount of bony stability. The glenohumeral joint doesn't have that. So what are the supporting structures for it then? Well, the labrum, and we'll illustrate that here in a minute, the joint capsule, the glenohumeral ligaments, the coracohumeral ligaments, and the surrounding structure. Now, one of the things that I give to the students already that I need to give to you is that anatomists are not very exciting people, at least not to go hang out at a party with, because their names aren't very creative. It's typically for what it connects, the shape, the action. So if we look here, we hear glenohumeral ligaments. Well, it's going to glenoid fossa to the humerus. Coracohumeral ligaments. Well, it's going from the coracoid process to the humerus. Okay, so that gives you just some idea what we're talking about here. So now let's look at a picture of the shoulder anatomy. And this is taken from MetaVisuals, as you see down here. Here is the head of the humerus. Then we see the glenoid fossa. Right around off of the what looks like it's coming right off of the labrum. This is actually the long head of the biceps tendon. Now it originates actually from the supraglenoid tubercle, which we see here. Now what does that mean? Superior portion of the glenoid fossa. And there's a tubercle right there, and that's their origination point. So the biceps, we can see from this image alone that, hey man, this probably has something to do with shoulder stability because it's crossing 2 joints. Versus what everybody always says, oh, you don't need to do biceps, curls are for the girls. Well, that while that's a politically incorrect statement, it's not just for looks. It actually has a tremendous amount of function as far as shoulder stabilization goes. And you can check out an article by Mike Lawrence looking at unstable bench press, and they illustrate how much the activity of the biceps brachii goes up with that, just to illustrate. just for some more quick things to be able to know which way we're facing whenever you're looking at something. The coracoid process for the shoulder is going to indicate the front. The acromion is going to indicate the back. Also, you would have the scapula. This is the coracoacromial ligament. It goes from the coracoid process to the acromion, and it serves as sort of a roof for the head of the humerus, so it doesn't continue to translate superiorly. We have a subacromial bursa to help dampen the blow if the humerus does come up and hit the acromion. We see an infraspinatus right here. We see a teres minor right here, probably latissimus dorsi, glenoid fossa, biceps tendon of the short head as it's coming up and inserting into the coracoid, originating off the coracoid process. Now, around this humeral head, we see this capsular ligament, and this is a joint capsule that helps with stability. This is actually pretty lax for a joint capsule. Why? Well, we have a tremendous amount of range of motion, and if we tighten the capsule down too much, we're going to restrict range of motion. And that actually used to be a surgery that they would do, and I don't know if it's still very in vogue, but back in the late 90s, early 2000s, if somebody had repeated dislocations, they would go down and they would remove some of the joint capsule. They would tighten it up. Well, that ended up limiting the range of motion. Which is great for not having a future shoulder dislocation, but it's pretty horrible if you are trying to get your arm up over your head to catch a ball. So, you've got trade-offs there. Now, note how flat that glenoid fossa looks. They're completely flat. I mean, we're looking at like the size of a quarter and the depth of those ridges. That's extremely flat. So what are we going to do? Well, we've got this labrum here, and this is from Veritas Health. This labrum deepens the socket. So this labrum exists on the glenoid fossa, and that is the job of the labrum in any condition. And while we're here, let's also talk about two different things. We see the nice shiny white thing in here, and it's lunchtime for me, and I'm getting hungry, so I'm thinking about this. But this is our example of articular cartilage, how it goes and coats the surface to try and decrease friction. Then the labrum is hyaline cartilage, which is very, very thick and dense, and it helps increase stability, and it also serves as a cushion. Outside of that, again, is the joint capsule. Okay, to increase the tensile strength here. So we see, here's the labrum again, and it's a ring of fibrous and tissue and fibrocartilage. So it's that hyaline cartilage surrounding the edge of the glenoid fossa. It increases the depth of the fossa, and it also increases the articular surface of contact area. So with those two things, if we increase the depth and how much area is in contact, we're going to increase the stability. Now, it also decreases the stress on the glenoid fossa. Well, how does it do that? Well, that labrum creates additional space to where they keep the head of the humerus from hitting that glenoid fossa. So it serves as a bumper cushioning zone. Kind of think about like a shocks or struts on a car. It's going to smooth out the ride, and it's going to cause less jarring. So with the capsule, again, we've talked about how it is loose. And it's about twice the size of the head of the humerus. So we need to have extreme laxity there. Now, that laxity allows for the general glenohumeral joint motion, but it doesn't really increase the stability a tremendous amount like it does in other synovial joints. Now, the capsule, when is it going to be the tightest, so create the most tension in there, which often is stability, but for this position it's not. Well, it's abducted to about 90 degrees and externally rotated. So think about if you made an L with your elbow and then you made an L with your shoulder and you've got it straight out to the side. That would be like coming over the top for a pitch or throwing a football, so in that top position. That's going to be our position of closed pack. Now that closed pack, all that means is that typically it's the greatest stability, but it is the most bone-on-bone position. The capsule is slackened in the open pack position. Now that open pack position happens to be scaption, so or the plane of the scapula. Now, the plane of the scapula, don't remember if we're going to hit that in this lecture or if that's in another, but it's about 20, 30 degrees off of that frontal plane. So whenever the arm goes forward in that plane to about 20 to 30 degrees, it's going in with the plane of the scapula, and that's called scaption, which is that open pack position. Then here we see that 30 degrees of scaption. Now the infia, what does it feel like? Well, whenever you get somebody all the way externally rotated, it feels firm. Like you could probably push harder if you wanted, but it's going to be at a very, very detrimental risk for the individual. It's got that firm infeel. Why? Well, we've got all of our ligamentous tightening. We've got the capsule tightening up to its greatest amount. And also, the muscles are tight. And that's what's causing that firm infeel. Now, let's talk about the rotator cuff. I had to go through all of that so we could get here to the rotator cuff, what I really wanted to share with you guys today. Most people have heard the SITs, the supraspinatus, infraspinatus, teres minor, and subscapularis. And that goes in order from top to bottom and then around to the front. And let's get to those muscles. So here we see the round to the front. This is the subscapularis. We know that we're looking at a front view because we see the coracoid process. So the subscapularis originates just a little bit inside that medial border. And it wraps around, it inserts onto the lateral side of that bicipital groove, just past the biceps brachial tendon. Posteriorly, supraspinatus. Okay, it originates in the supraspinous fossa, which is above the spine of the scapula, goes under the roof of the acromion, as we can see here, and inserts into the lateral edge, which is going to help it with abduction. Our infraspinatus lies in the infraspinatus fossa, or inferior to the spine of the scapula. And then our teres minor originates just above the inferior angle. So it's just superior to the teres major. Superior meaning above, not meaning better. Okay. So the supraspinatus, what does it do? Well, it does shoulder abduction. Now, based off of the position of the shoulder, we know that, man, if we think about this, all the muscle can do is shorten, right? Sliding filament theory, the concentric contraction is the actin being drawn across the myosin. Well, whenever that occurs, all it's going to do is shorten the muscle, right? Well, if we think about the origin of the deltoid, and while we're not talking about that right now, we're going to go ahead and show this, that if the origin of the deltoid is off of your clavicle and off of the spine of the scapula and going around towards the acromion, well, if all it can do is shorten, if my arm is at my side, that line of pull is just going to be straight up. So that's actually going to cause the head of the humerus to hit the acromion rather than to cause abduction. Well, the supraspinatus, with its line of pull, it will start that first 20 or 30 degrees of abduction and allow the deltoid to get into a mechanical advantage to where we have a line of pull that's going to go for not compression, but abduction. After we get up to about 90 degrees, and even just after we get past that 30 degrees, more and more of the supraspinatus action actually goes to compression of the joint, and then whenever we're at 90 degrees, it's all compression. The origin of it, okay, you'll see OIAN on this, and then BS. O stands for origin, I stands for insertion, A stands for action, N stands for nerve, and the BS stands for blood supply. I don't really require my students to know the blood supply so much. The nerve is bonus as far as I'm concerned, but I do expect the origin, insertion, and action. And here we see from Visible Body. Now, this is a plug for Visible Body. This is one of my two favorite apps for anatomy. I really like the way that it isolates in, and then it'll tell you all the information that you want to know. The downside, a couple of them are wrong. Like the short head of the bicep, it said that the origin was the supraglenoid tubercle. It's not. It's the coracoid process. But that's, and they might have fixed that, and I just haven't updated. But here we see the origin of the origin right here, the supraspinatus fossa. It comes out and it goes onto that lateral aspect. And then it's just going to bloop, pull straight back, and that's going to cause the abduction. The infraspinatus, it's a lateral rotator, and it's going to assist with horizontal abduction. So horizontal abduction is Think about if you get on the pec deck and you turn around and you're pulling the shoulders back together. Think about retraction of the shoulder blade. Well, that's going to be that horizontal abduction as well. Lateral rotation is the same as external rotation. It just depends on the source that you're getting it from as to what they call it. It's going to be stabilization of the glenohumeral joint. The infraspinatus fossa is the origin. It inserts in the humerus. It's a lateral rotator, subscapular nerve. And here we see it again with visible body. We look at the origin here in the infraspinatus fossa. We see the line of pull as it goes onto the posterior lateral portion of the head of the humerus. And then it would shorten and cause external or lateral rotation. Now the teres minor, lateral rotator, weak adductor, and it's a stabilizer, of course. Here's origin, insertion, action, lateral border of the scapula. It inserts into the humerus, and it's lateral rotator of the arm with the axillary nerve. And we see here with our visible body slide, there's the teres minor right there coming off, and this would be the teres major just below it. Now let's get to the subscapularis, the last muscle of the shoulder blade, rotator cuff, excuse me. The subscapularis is actually a medial or internal rotator. It's a very weak sister whenever we're dealing with flexion, extension, adduction, abduction, and what it's like. Oh, it does all of that. It depends on the position of the arm for what action that it's going to have. That's one of the downsides of a 360-degree joint. But we look at the origin, subscapular fossa, insertion into the anterior portion of the humerus, and the action is going to be medial or internal rotation, subscapular nerve, branches subscapular artery. And if I could actually hide the ribs and everything, but I wanted to leave them there just so you could get a appreciation for it. We see how it comes off of just inside that medial border, inserts into the lateral anterior portion of the humerus. Again, coracoid process could be a landmark for us. We can see how it would internally rotate. Now, all four of these muscles function together to dynamically stabilize the head of the humerus and the glenoid fossa during shoulder motion. The contraction of these rotator cuff muscles prevents the anterior and posterior gliding of the glenohumeral joint during abduction, and may also prevent superior glide of the humeral head during shoulder elevation. So really what this is, they call it rotator cuff, and I almost feel like it should be called a compression cuff, because its job isn't just to rotate and turn it forward and back and just whatever. It works synergistically. All of them are working together at the same time to keep the head of the humerus centrated. Now, this goes back to what we were talking about earlier, the coordination of the deltoid and the rotator cuff. In neutral, so this would be called fundamental standing position, which is with your hands down by your side and the palm of your hand facing your thigh. In neutral, the line of pull, the middle deltoid, is directed mostly superiorly, so that it produces superior translation of the humeral head on the glenoid fossa. The supraspinatus has a better line of pull to initiate the rotation of the humeral head and facilitates abduction. So this means that it's an anatomical force couple, which means that we've got two different muscles working in two different regimes almost to cause one motion. So to actually powerfully abduct, it's going to require both of those muscles. Now, what happens if you don't have a supraspinatus or there's an injury to it? Well, your body is full of redundancies, and your trapezius is like, man, I got you. And the upper trapezius will elevate the scapula to the point where the deltoid can pull on. So basically, if you see somebody have to shrug their shoulder up to stick their arm out to the side, they had a supraspinatus injury. So that's one of those kind of cool things that you can watch. And it'll also tell you that, hey, this person is dominating by trapezius and their supraspinatus isn't working, and on lateral raises even. So you see them on lateral raises, if they're shrugging their shoulders up to get it moving, it means one of two things. Either it means that the weight is too heavy, or they've got a really weak or injured supraspinatus. So let's look at this line of pull in A. The deltoid, we can see that it's basically straight vertical, right? And these are all line of pull. This is for the supraspinatus, for the solid line up top. The dotted line below it is infraspinatus. The solid line below that is subscapularis. And the dotted line below that is teres minor. Now we see the D. Okay, we see that the D, that's dark and solid, is going up, and that's called a resultant force. That would be the line of pull. DS talks about stability, and DR talks about rotation. And this, if we go to the resolution of and composition of forces, we would do that, but who cares? I know none of you guys care. What if we look here, we see all the line of pull is to keep, while the deltoid is trying to pull it up, all of the rotator cuff muscles, excluding the supraspinatus, but it'll turn on to do that here in a minute, are pulling down and in to hold that position of that congruence for the humerus on the glenoid fossa. And we see how that continues in B. So as the deltoid contracts at the beginning of elevation, the teres minor, infraspinatus, and subscapularis contract, applying inferior force. Inferior, not saying that it's subjugated by, but it means that it's just pulling down on the humeral head, preventing excessive superior glide of the humeral head, which is going to slide up, and it's going to hit the head of the head of the humerus would hit the acromion, and that's impingement, guys. This is another example of a force couple. Upward and downward pulls of the muscles are balanced, and all forces are contributed to abduction. So abduction of the shoulder is going to require the shoulder, the deltoid strength, the supraspinatus for mechanical advantage, and then the depressors of the humeral head, which are the rest of the rotator cuff muscles. So really, what this is saying is that your rotator cuff, yeah, you know what, you can get some stuff, you can do some improvements with the internal and external rotation, but hey man, that's not how it works. So you might want to do some things that are going more towards how the rotator cuff works as a stabilizer rather than a prime mover. Okay, pick up something heavy, move it around, rotate it, whatever you do, try and work on the position of the glenohumeral joint on that glenoid fossa. Position of the humeral head on the glenoid fossa. Because that's what it's all about. That's really the purpose of the rotator cuff. As we see here, this is just one more figure illustrating that fact. If you want more information about this, if it's something that really sparks your academic interest, please feel free to come see us at the U. Here is the site that you can find more information about our applied physiology, which strength conditioning is a part of, and we will soon have a link for some of the coaching education courses that we're developing that are, it's not for towards a degree, it's just towards continuing your education, and it's approved through the NSCA for continuing education units. So look forward to seeing you more, hopefully, and be involved with what we're doing down here at the U. Thank you.